and welcome back to my channel. So we have started the preparation for gynecology subject and we have covered all the topics. The only topic that is remaining is ovarian cyst and tumor. So this is the last video for gynecology subject. If I want to revise or if we want to prep for the prof exam or any other videos, then I will definitely upload. But this is the last lecture of this series of our revision. So coming towards the today's topic, that is ovarian cyst and tumor, and then we are done with the gynecology. So we are having a scenario that there is a 35-year-old lady present with ovarian cyst 8 centimeter and ascites is present. So what is the management? Another scenario is that there is a 25-year-old para 3 complaints of abdominal discomfort and menstrual disturbance. Ultrasound scan shows 6 centimeter unilocular ovarian cyst. What are the differential diagnoses of the mass abdomen? The management. If similar cyst in female greater than 30 years, then what is management? The investigations, complications, advantages of laparoscopic surgery. Another scenario is that there is a 40-year-old ovarian mass. What is the follow-up? The difference between the benign and the malignant cyst. Okay, so now coming towards ovarian tumors, we are having both the benign ovarian tumors and malignant ovarian tumors. We will compare both of this, so it is easy for us to remember it. So benign tumors are cystic masses, malignant tumors are partially solid and cystic masses. Benign tumors are mostly unilateral, malignant tumors are mostly bilateral. Benign tumors are freely mobile while malignant are restricted mobility. The benign tumor's surface is smooth while the malignant surface is irregular. Benign tumors are less than 8 to 10 centimeter while malignant tumors are greater than 10 centimeter. In benign tumor, it is confined to inside of the capsule and malignant tumor is fungating through the capsule. Benign tumors have no free or blood-stained peritoneal fluid and malignant tumors are free or blood-stained peritoneal fluid. Benign tumors are absolute of adhesions while malignant are presence of adhesions. Benign have no papillary vegetations inside the cyst while malignant tumor have papillary vegetation inside the cyst. Benign tumors are small or no blood vessels on surface are present while the malignant tumors are large and blood vessels on surface are present. There is no area of hemorrhage showing through outer wall while in malignant tumor area of hemorrhage showing through the outer wall is present. In benign tumor, there is no area of hemorrhage showing through outer wall, and in the malignant tumor, okay, I have repeated this. Now, the benign tumors are not palpable lymph nodes or metastasis is present, and they are not lobulated, and no torsion and no tenderness is present, and the absence of malignant cells on cytological examination is there on the benign tumors. While in malignant tumors, palpable lymph node or metastasis in the liver or omentum is present, they are lobulated, torsion is present, they are tender. The presence of malignant cells on cytological examination of ascitic fluid and peritoneal washing is present. So this is the basic difference between the benign tumors and the malignant tumors. Now coming towards the management options, we are having history taking, that is the history of the irregular menstruation, post-menstrual bleeding, sudden weight loss, abdominal pain and feeling of abdominal mass, history of pressure symptoms. The examinations are GP is done, that is pallor, lymph nodes, breast examination, etc. Then on abdominal examination, when tumor is confined to pelvis, it is normal. In advanced stages, it appears distended, shiny with prominent veins. On palpation, it's fixed, hard, tender, and has irregular mass. In case of ascites, shifting dullness and fluid thrill is positive, and decreased vowel sounds or auscultation is present. On pelvic examination, bimanual examination shows firm, tender, irregular mass, restricted mobility, difficult to separate from uterus. On rectal examination, it is for hemorrhoids. Investigations are done, which are routine investigations. That is CBC, blood group, blood sugar, urinary, hepatitis B and C screening, and HIV screening. Ultrasound is specifically done. It is useful in detecting small ovarian tumors. It helps to differentiate retention cyst from neoplasm. It tells us about the tumor size. Then color Doppler is done, which shows the presence of ascitic fluid, and plain X-ray abdomen or X-ray chest is done. That is IVU, barium studies, and CT scan or MRI for the diagnosis of enlarged lymph nodes. Laparoscopy is done and exfoliative cytology is done. Tumor markers are done. There is carcinoma 125, HCG, CEA, alpha fetoprotein, and LDH. The treatment options include surgery, chemotherapy, and radiotherapy. Now, surgery. Regardless of how severe the tumor is, Okay, regardless of how severe the tumor is, initial step is in the treatment is to perform laparotomy. Surgical options depend on the type of the tumor. Then benign tumors, for benign tumors, cystectomy, unilateral oophorectomy, salpingo-oophorectomy is performed. In postmenopausal women, total abdominal hysterectomy and bilateral salpingo-oophorectomy is performed. The borderline tumors in young patient in conservative treatment in cystectomy, in unilateral oophorectomy and unilateral salpingectomy is done. In older patients, the total abdominal hysterectomy with bilateral salpingo-oophorectomy is done, and malignant tumors treatment depends on the stage and grade of the tumor. Then we have stage 1 and B and grade 1. So the total abdominal hysterectomy, bilateral salpingo-oophorectomy in young patients and close follow-up should be done. In stage 1A and 1B with grade 2 or 3 or stage 1C, total abdominal hysterectomy and bilateral salpingo-oophorectomy is performed, which is followed by chemotherapy or radiotherapy. Stage 2 and 3 and 4, total abdominal hysterectomy with bilateral salpingo-oophorectomy and chemotherapy plus radiotherapy, and it should be removed as much as possible, include metastasis. Debulking of the tumor is done and cytoreduction of the tumor is done. In the grading of tumor, we are having 3 grades. Grade 1 is well differentiated, grade 2 moderately well differentiated, and grade 3 is poorly differentiated. Then we will do the radiotherapy, that is post-op irradiation of the whole abdomen, and second look laparotomy to assess the benefit of the treatment and to decide the further management. Okay, follow-up is done. That is, follow-up is done by prognosis. Clinically, carcinoma 125 and ultrasound is done. The stages are stage 1, 2, 3 and 4. Stage 1 is 60 to 70%, stage 2 30%, stage 3 10% and stage 4 is 5%. Okay, this shows the 5-year survival rate. The complications of the ovarian tumors are torsion, ruptured cyst, hemorrhage, degeneration, infections, malignancy in benign tumors, intestinal obstructions. The differential diagnoses are distended urinary bladder, pregnancy, that is uterine or ectopic, uterine swelling, retroverted uterus, endometriosis, ascites, hydrated cyst, tumor of the colon and rectum, and pelvis abscess. The infections of the lower genital tract, the infections of upper genital tract, pelvic tuberculosis, urinary incontinence in women, fistulas, intersexuality, diseases of the cervix, diseases of the vulva, and diseases of the vagina. So these are the these are the ovarian cyst tumors. Okay, so let's revise what we have discussed up till now. We have discussed the ovarian cyst tumor. We have discussed the scenario that there is a 35-year-old lady who presented with ovarian cyst of 8 cm and ascites is also present. So, patient is complaining of abdominal discomfort and menstrual disturbance. Ultrasound scale shows 6 cm unilocular ovarian cyst. So that the differential diagnosis of mass abdomen, the management, and if similar cyst in female, then how you will manage. Okay. So the differential diagnosis have we studied. Okay, these are the stages, the gradings, and the surgery, treatment, investigations, management. Okay, so what are the complications and advantages of laparoscopic surgery and how you will do the follow-up. So we have discussed the difference between ovarian tumors, we have benign tumors and malignant tumors and the difference between them. Then we have discussed the management option. First of all, history check and then examination in GP and then abdominal examination. And in case of ascites, shift and dullness will be present, then pelvic examination is done and rectal examination is done. Investigations, routine investigations are done, ultrasound is done, color Doppler is done, plain X-ray abdomen and X-ray chest is done. Laparoscopy, exfoliative cytology and tumor markers are done, which are carcinoma 125, HCG, CEA, alpha-fetoprotein and LDH. Then the treatment options are surgery, chemotherapy and radiotherapy. So surgery, regardless of how severe the tumor is, initial step is the treatment to perform laparotomy. Then we are having the benign tumors in postmenopausal women and borderline tumors. For these, the surgical operations. Then in older patients, this total abdominal hysterectomy with bilateral salpingo-oophorectomy is performed. For malignant tumors, treatment depends on the stage and grade of the tumor. If it is stage 1 and 1B or grade 1, then the total abdominal hysterectomy, bilateral salpingo-oophorectomy and close follow-up should be done. If it is stage 1E, 1B with grade 2 and 3 or stage 1C, then total abdominal hysterectomy and bilateral salpingo-oophorectomy followed by chemotherapy and radiotherapy. If it is stage 2, 3 and 4, then total abdominal hysterectomy with bilateral salpingo-oophorectomy and chemotherapy or radiotherapy, and it should be removed as much as possible in studies. Now the grading of tumor is grade 1, grade 2 and grade 3. The radiotherapy is provided post-op irradiation of the whole abdomen and second look laparotomy, and to assess the benefit of the treatment to decide further management. Then follow-up is done by prognosis diagnosis, that is clinically, then carcinoma 125 and ultrasound is done. And then we have discussed the complications, which is torsion and rupture, cyst, hemorrhage, degeneration, infections, malignancy, and benign tumors. And in the end, we have discussed the differential diagnosis. That what are the differential diagnosis of mass abdomen. So these are distended urinary bladder and pregnancy, uterine swelling, retroverted uterus, endometriosis and ascites, hydrated cyst, and tumor of colon and rectum, and pelvic abscess. All these are the differential diagnosis of the mass abdomen. So here we have completed the revision for the gynecology subject, and we have remaining some topics for the OPS. So I will also complete that playlist. So don't forget to like this video and subscribe my channel for further videos. Thanks for watching.